Hi, welcome to everybody. My name is Emanuele Rando, and I'm a junior doctor in Rome at the University of the Sacred Heart. And I'm going to take a lesson about malaria. Of course, the aim of this lesson is just to evaluate some clinical aspects about clinical manifestation and diagnosis, even about the blood smears or the rapid diagnostic test, and even a short course on therapy about uncomplicated malaria and even severe malaria. The title is Clinical, Epidemiological Prophylaxis and Therapeutic Management of Malaria. So I just want to start saying that malaria has a long history, not only just as disease, but even in human history. For example, William Osler, a famous Canadian physician, told a long time ago that humanity has but three great enemies: fever, famine, and war. And of these, by far the greatest, by far the most terrible, is fever. And because, of course, here the situation is quite different, but in the past, infectious diseases were the most terrible and the most frequent cause of death around the world for humans. And even malaria is an ancient disease. The Plasmodium parasites affects humans since the beginning of human life, and probably humans caught the disease from primates as other disease, even HIV, for example. And we always say that malaria is a problem, and even the WHO say that a malaria problem exists, because there are two aspects to consider: the direct burden of malaria, and it consists mainly in morbidity and mortality of the disease. Because, for example, here the WHO estimates that in 2019 there were 409,000 deaths because of malaria, and the majority of them are children, as you probably know. And there is also an indirect burden of malaria. That's the impact on human development and economics. Because, for example, there was a study published in Nature that estimates that a single episode of malaria can result in a loss of 5 to 10 working days. And this is a problem, especially in areas when workers are paid daily and not with a salary or other form of payment. And I also bring you a book that I read a long time ago by William McNeill, a Canadian historian, because probably there's also an fascinating aspects of diseases, because there are strange liaison, a sort of link between human history and infectious diseases. Because in the book, the author attributes a considerable importance to periodic fevers influencing human history and migrations. And here, for example, there's a picture from the China geographical area, where we can see the Yellow River above and the Yangtze River below. And it was strange because in the past, Chinese tended to live on the northern China, where the climate is more severe, the earth is less fertile, and even the river was particularly dangerous for men, because there were some Chinese books that reported that if people go in southern China, they got fever and they died. So it was probably malaria in that case, or other viral fevers that restrained the human migration and even human activities. So we know that malaria is a vector-borne disease, and it is caused by a single cell parasite called Plasmodium, and that it's transmitted by female Anopheles mosquitoes. And in this picture, you can see it's taken from the Nectar Infectious Diseases about the cycle of malaria. So the Plasmodium is an obligate parasite, is a different form, of course, of agents, different from bacteria and even from virus. Probably the first infectious agents in the human history, And there are numerous species of Plasmodium, for example, Plasmodium falciparum, vivax, ovale, malaria, and knowlesi, but it's like quite different, especially in southern East Asia. And we can also see a picture where the parasite is attaching to the rod to human red blood cells to enter and to replicate. So here we can see the global incidence of malaria, and we can clearly see that the vast majority of cases occurs in sub-Saharan Africa, and even, of course, in other parts of the world, like the South and Eastern Asia, in India, in Oceania, and in South America, but the vast majority of cases are in Africa. And here we can see also a map with the incidence of a distribution of Plasmodium falciparum, and it's quite iconic, I can say. Or even in this case, the majority of cases are reported in sub-Saharan Africa. For Plasmodium vivax, the situation is a little bit different, especially in India. Also from Plasmodium ovale, there are some difference because it's quite it's less frequent than Plasmodium falciparum, even less important from a clinical point of view. And even Plasmodium knowlesi in Cambodia, Thailand, and Philippines. And it is important because it can cause severe malaria, but it's not transmitted. The cycle is a little bit different because probably humans caught the Plasmodium from primates. So the infections, I say, all starts with a bite because there are some phases of the malaria infections. For example, the first is all starts with the mosquito bite that inoculates porocytes, they go to the liver within 1 to 2 hours. Then they invade hepatocytes and divide to form multinucleated schizons. The schizons then rupture and release merozoite that go into blood cells, and then especially erythrocyte, of course. And then they can even differentiate to female or male gametocytes that are acquired by the mosquito, and then the cycle can continue. This is important also because there are some difference from an epidemiological aspects point of view in Africa and Southeast Asia. Because sometimes, in Africa, people get bite even 1 time a day, even more frequently. While in Asia, the situation is a little bit different because people can get bite just 1 time a year. And despite this fact, we know very well that the majority of malaria-resistant cases are for reasons that probably we would poorly understand in Asia and not in Africa. So here there's even a slide about the incubation time, and it varies along the species of Plasmodium, of course. For example, for Plasmodium falciparum, it can range from 8 days to 25 days. For Plasmodium vivax, from 10 days to 30 days. And from Plasmodium ovale, from 10 to 20 days. And from Plasmodium malaria, from 15 to 35 days. Of course, we should consider malaria even with a little bit difference from the reported range, because sometimes we can expect, for example, a presentation of a Plasmodium falciparum malaria even after 5 days of a mosquito bite. So it's quite different. Probably this is just a scholastic slide, but you should always consider malaria. So, and here I just want to put the attention on the 2 forms that the WHO would recognize, but probably are important even from a clinical point of view, because there are 2 forms of malaria. We say uncomplicated malaria and severe malaria. So uncomplicated malaria is defined as a symptomatic infection due to Plasmodium falciparum in patients able to swallow medicines in the absence of symptoms and signs consistent with severe malaria. The mortality approaches less than 0.1%, so it's quite an indolent disease. And it should be suspected primarily in case of fever or an history of fever. Initial symptoms are quite there are some variation, of course, because malaria can present in a typical way. People can have tachycardia, tachypnea, chills, malaise, fatigue, diaphoresis, headache, cough, anorexia, and so on. So the presentation can be quite specific, especially because other viruses, for example, viral infections, have the same presentation, and even bacterial infection. So it's quite difficult just from a clinical point of view to differentiate between malaria and other form of disease. And probably there's the history, the epidemiological link is the most important thing to consider. And even from physical and laboratory findings, we can have a splenomegaly, not always present, jaundice, anemia, thrombocytopenia, and abnormalities of a liver function test. And in this case, I just want to ask you, in your experience, what are the majority of the major findings you note when you approach malaria, when you have patients with malaria, even from a symptomatic point of view, but even in laboratory findings or other physical examination? It's quite important even for us to know, because sometimes with the diagnosis malaria primarily because of a history of travel and fever, and we don't assist to some other manifestation.
You have outlined them very well. I can contribute that sometimes they come with neurological symptoms or syndrome, where there's positive history of convulsion.
Yeah.
The child or the patient is, of course, with high fever, is lethargic.
Mm-hmm. Yeah, right. Especially, I imagine, especially in severe malaria, of course.
Yes,
yeah.
In severe malaria, yes.
Yeah. Mm-hmm.
This one are general, so we are bringing in that all the symptoms.
Okay.
Others can also be asymptomatic. The patient is just having general body malaise and is having a fever, and you also have to find out where the patient is living. In most cases, those who are living up country, like if you travel to go and visit a country and you come in the center, this is Kampala, you may find that the child is just weak and also jaundice,
okay,
and severe anemia, that he has stayed with that condition for some time.
Yeah, okay. Yeah, understood. That's clear. But yeah, it's an important thing, especially for a great clinician, I have to say, because you can recognize, you can have a sort of feeling to recognize malaria, even in asymptomatic patients like that you describe. So yeah, it's quite important even for us. Thank you. And so let's go ahead. And here there's a slide with the WHO definition of severe malaria. We can say, of course, as we said just before, impaired consciousness, so coma or other neurological manifestation, prostration, weakness in particular, seizure or convulsion, as you said, acidosis. Even if in this case you should take a blood sample to do an arterial blood gas. Hypoglycemia, severe malarial anemia defined as an hemoglobin concentration less than 5 gram deciliter, renal impairment, jaundice, pulmonary edema, significant bleeding, not only from the nose, gums, or venipuncture, but even from, for example, hemoglobinuria and other renal signs of bleeding, shock, and hyperparasitemia, defined as Plasmodium falciparum parasitemia greater than 10%. for us, I understand it's quite, for example, sometimes easy to take a blood sample to perform an arterial blood gas and even to see the levels of bicarbonate in the blood or the plasma lactate. I don't know if you sometimes maybe in your experience it's quite easier to define severe malaria based on the neurological manifestation, as you said, like coma or seizure. Do you routinely take blood samples to explore acidosis or hypoglycemia in the first hour of presentation?
Yes, we do. Of course, when you are confronted with this case, here at Benedict, we have a well-set laboratory. We take off blood, we do a test from a rapid diagnostic test and microscopy. We also ask a complete blood count, of which when you do a complete blood count, you will see that the white blood cells have lowered, the neutrophil is raised, you will see that the HB is also lowered due to the destruction of red blood cells. You also see the platelets is also lowered.
Yeah,
so
of course.
We do character investigations from the hospital.
Okay, perfect. Thank you. Thank you.
Daniela's hand is up.
Yeah.
I wanted to say, maybe you were asking about hemogas analysis. That machine is quite rare in Uganda. In our facilities, in our size, we don't have. I think maybe Bio can tell. I think it's only Mulago. Thank you.
Yeah, blood gases, it's a luxury here to have blood gases done, and usually it is in ICU settings that one may have the blood gas done. Okay, thank you.
Yeah, it's even quite invasive as a test, so yeah, it may be more appropriate for an intensive care unit. Okay, thank you. And so, who is at risk for severe malaria in this case? Not uncomplicated malaria, but severe malaria, so the form that causes the majority of deaths. And here I put a picture taken from the World Malaria Report by the WHO in 2019. I think it's quite emblematic, it's quite iconic. So in areas where malaria is endemic, young children and pregnant women, and maybe even travelers to areas where malaria is endemic with no previous exposure because they haven't developed any form of immunity. Here, there's even a picture from a book about the relative incidence of severe complication of falciparum malaria in 3 kind of patients: non-pregnant adults, pregnant women, and children. And as we can see here, children are more likely to experience anemia, convulsion, and hypoglycemia. And renal failure is not a frequent complication in this case. While in pregnant women, we can see more frequently hypoglycemia, jaundice, renal failure, and pulmonary edema. So quite a lot of manifestation of severe malaria. Here, I don't just want to bother you with a lot of pathophysiology, but I just want to report some notes and about Plasmodium falciparum malaria and even severe malaria in this case, because an iconic ability of the Plasmodium is to alter red blood cells, not only in their form, but even in the exposure of some elements in the membrane, in the outer membrane, and they just get trapped in a deep venous microvasculature. They adhere to small blood vessels, and there they can cause small infarcts, capillary leakage, and organ dysfunction. And this is also the importance and the morbidity of severe malaria, and even it explains the majority of clinical manifestation we can see, like convulsion, cerebral malaria, renal failure, and even pulmonary edema. Here, for example, I reported a slide from a study from in a review where we can see how Plasmodium can form rosettes of erythrocytes. They can adhere to endothelial cell, and there they can occlude microvasculature, because they can explain erythrocyte infected by the Plasmodium can alter the membrane. They can express different form of human proteins, but even a different form of Plasmodium proteins. And they are even important in developing immunity, a sort of immunity of tolerance of the organism in case of a repeating exposure to malaria. And I just want to even to talk about Celibate Malaria. It's a form of encephalopathy and that presents with impaired consciousness, delirium, even if focal neurological signs are quite unusual. And it has been associated with death rates of approximately 20% among adults and approximately 15% among children. In this case, as you said before, sometimes people can appear just different from their habits. They are weak, just a little bit lethargic, but it's not so evident sometimes. So a high index of suspicion is needed. And I even just want to show you a study performed in India, because it's important, because sometimes there are no studies using expensive diagnostics tests like in this study, because these colleagues used MRI to watch for a modification in a brain from an anatomical perspective and even from a metabolic perspective in severe malaria and in case of cerebral malaria. And they reported that in the posterior part of the brain, there are some form of both cytotoxic edema and even vascular vasogenic edema. So it's like a posterior encephalopathy. And it was a bit important even to understand and to know better, to better know the pathophysiology of the disease. So we can do the diagnosis, and as we said before, signs and symptoms are quite non-specific. We should always suspect malaria in case of fever and in an appropriate epidemiological context. In our case, for example, is a history of travel, and it's quite it's more frequent, of course. And in that case, there's an indication for a diagnostic test. We can use a light microscopy with a direct visualization of parasites, or a rapid diagnostic test with the detection of antigen or antibody. Light microscopy, of course, is the gold standard. It has some advantages, but even drawbacks. About the advantages, we can visually detect blood parasites, even identify the Plasmodium species, and we can quantify parasitemia. Of course, it's operator dependent, and there can be some errors if there are low density parasitemia. It exists just two types of smears, thin smear and thick smear. And they differ a little bit, because in the thick smear, you just can destroy red blood cells. The charge of the parasitemia, maybe the charge of parasite can be more evident, but you can't see the parasite inside blood cells. Like in the thin smear, you can do that. Here you can see, for example, a picture from Netter's infectious disease about the thick blood smear appears, and in the right side of the slide as thin blood smear appears. And in the thin blood smear, so we can see, for example, trophozoites into the blood cells, while in the thick, we can see trophozoites outside and even gametocytes. So when should we collect the blood sample? In three main cases, of course. As soon as possible, if malaria is suspected, and during peaks of fever, and even before the patient receives anti-malarial drugs, because in that case, we could alter parasite morphology. And however, this is of course important, if malaria is still suspected and the initial smear is negative, an additional smears should be prepared and examined over the subsequent hours. And a little excursus about the rapid diagnosis test. When they can, with that we can detect malaria parasite antigens or antibody developed by the human system, and they just provide the presence or not of the parasites in the blood, but they cannot quantify the charge of that, so we can say anything about parasitemia, and we can't say anything about the Plasmodium species implicated in that specific case. However, they are some important because we can have rapid results, and in our experience, it is important in case when we suspect malaria and a blood smear is negative, sometimes we perform a rapid diagnostics test to ascertain if the patient has or not malaria in the blood. It's quite easy for us to perform, and even important. I don't know in your experience if you use rapid diagnostics test, and if they are so important or they can change clinical aspects in the management of patients. And I just want to know about your experience.
They are very important. We use them a lot.
Okay, perfect. Okay, I imagine. Okay. So let's go ahead and let's talk about treatment. In this case, treatment of uncomplicated malaria. The cornerstone is the artemisinin-based combination therapy, or ACT, from the WHO guidelines for malaria. And for children and adults, we can use some drugs. Here I reported 5 drug combination. For example, artemether lumefantrine, artesunate amodiaquine, artesunate mefloquine, dihydroartemisinin plus piperacin, and artesunate plus sulfadoxine pyrimethamine. In that case, the WHO gives a strong recommendation with high certainty evidence that artemisinin-based combination is better than other drug, because ACTs have a low side effect profile. They are potent against all blood stages of the parasite, and they have the most rapid clearance time relative to other anti-malarial drugs. The artemisinin derivative has a short half-life, so the drug partner, clears the remaining parasites because it takes a long time to be cleared from the organism. Anyway, no combination has been proven to be superior to any other, so we can use any form of combination depending on of course, the availability of the drug, and even based on the patient we have in front of us. The duration is there's even in this case a strong recommendation with high certainty evidence that an ACT regimen should provide 3 days treatment with artemisinin derivatives, because there are 2 important trials where 3 days of artesunate reduce the PCR adjusted treatment failure rate by 60%, with a relative risk of 0.45%. So there was a high quality evidence in these trials. In the case of artemether lumefantrine, there's of course the target dose range, and the drug is given twice a day for 3 days, and this combination should be taken immediately after food or a fat-containing drink, for example, milk. It's quite iconic. We should anyway monitor treatment response, especially in young children, pregnant women, people who their body weight is greater than 65 kilograms, and patients taking mefloquine, rifampin, or rifavirenz. So especially people with or HIV or tuberculosis in the case, even smokers. In the case of artesunate amodiaquine, in this case, there are some adverse effects, especially severe neutropenia in patients co-infected with HIV, or people using trimetoprim, sulfamethoxazole, or cotrimoxazole. So in that case, the concomitant use should be avoided. In the case of mefloquine, mefloquine is a well-known drug known for the psychiatric complication and even increased evidence of nausea, vomiting, or dysphoria. So it should be avoided, especially in people with a history of a psychiatric condition. In this case, there's another well-used combination with the target dose and range. And and the hydroartesomycin plus piperacin. Piperacin is a drug known to clear hypnozoids or to have a longer half-life, so it can clear the remaining form of parasites after the efficacy of the artemisinin derivative. But the hydroartemisinin exposure is lower in pregnant women, even in this case. So when we define recurrent falciparum malaria in this case, we can talk about reinfection or treatment failure. We can make a difference between a failure within 28 days or failure after 28 days. The WHO recommend, in case of failure within 28 days, a second-line treatment as an alternative ACT, because in that case, probably the first drug was not effective at all or partially effective. In the case of failure after 28 days, in that case, probably we can even consider reinfection. In that case, using the drug we already have used before for the first case. In the case of severe malaria, in this case, of course, there are some differences, especially in the clinical management of patients, not only from a specific therapy point for the specific therapy of malaria, but even from the general complication of these patients and for the high level of attention they needed. Yeah, because death can occur within hours of admission, and the drug should be administered as soon as possible. There are two classes of medicine, artemisinin derivative, especially artesunate, or quinine and quinidine. However, WHO recommend parenteral artesunate as the first-line treatment if available. And here I reported part of WHO guidelines say that treat adults and children with severe malaria, even pregnant women in all trimester and lactating women, with intravenous or intramuscular artesunate. And there's also a recommendation about the duration of therapy. So once a patient has received at least 24 hours of parenteral therapy and they can tolerate oral therapy, they can complete treatment as uncomplicated malaria. Because there were some trials comparing quinine and parenteral artesunate, and they showed that a reduced mortality was expected using artesunate by about 24% in adults. So it's quite impressive results. And even in children, the mortality was reduced by about 25%. So the intravenous therapy, of course, should administer immediately if feasible. Otherwise, we can also use a different treatment, like, for example, per rectum or intramuscular therapy, if as a pre-referral dose. So before having the medical contact. Artesunate is a well-tolerated drug, even if there are some adverse effects, of course. The most common are nausea, vomiting, and anorexia, but it's quite difficult to differentiate between malaria symptoms and signs and artesunate adverse effect. But the most serious are neutropenia, anemia, hemolysis, and alteration in liver enzymes. In your experience, do you see frequently serious complication of artesunate, or is quite a well-tolerated drug?
It is quite well tolerated. We've not yet seen any serious adverse events to artesunate.
Oh, okay. Yeah, probably they are just reported in a brief case reports. They are quite rare. Okay, perfect. Thank you. Okay. Yeah.
Thank you very much. Like what Dr. Myers said, is quite well tolerated, apart from being expensive. It's expensive in the hospital, and it can also be expensive to community members, like in our community setting, but it's well tolerated. Thank you.
Okay. Okay.
In the government, in the public facility, it is supposed to be free of charge, but the supplies in the past years, because malaria infection is not constant throughout the year, it is the graph. The graph is up and down. So, sorry. According to the weather also. Like currently in the last few years, it was more in the north and eastern part of Uganda as compared to central and west and southern part of Uganda. So that was the last 2 years ago. And in this current year, the graph nationally is going down and down and down. But that does not mean that probably the malaria is going away completely. Now that the weather has turned to be rainy season right now, more cases might begin again to show up. Otherwise, as for now, the cases have lowered. The challenges the community face with the government facility is that the demand is high, the supply is low. So hence they come to the private. Usually they don't get the drug for free, so they have to charge. So if they can't afford, there is comparison, there is option. Since artesunate is more expensive as compared to quinine, so the option, the next option will go to quinine, which is
of course
affordable.
Okay, understood. And even in fact, even the WHO guidelines recommend intramuscular quinine or intravenous quinine when artesunate or artemether is not available. Of course, it's a problem in the case. Okay, and thank you. Anyway, thank you for your considerations. Here there was in fact a slide regarding the alternatives to artesunate and the use of quinine for treating children and adults with severe malaria, or the use of artemether when available by an intramuscular injection, then therapeutic. However, of course, if artemether is not available, intravenous quinine or quinidine may be administered as well. In this case, I just reported some additional consideration that if feasible, we should monitor parasite density, even if the clinical response is quite important as well, and even about the duration of therapy in endemic areas, and for example, for a minimum of 24 hours by intravenous therapy, and then switching to an oral therapy as soon as people can tolerate oral medication. About severe malaria in pregnancy, there are artesunate is well tolerated, for example, in the second or the third trimester without any adverse event for the fetus, even if there are no so well-conducted studies about the first part of pregnancy. But even in that case, for example, the WHO recommend the use of the jug. However, there are, of course, other supportive measures, especially respiratory support, in presence of hypoxia, treatment of seizures and neurological complication of the disease, anemia, and acute kidney injury. There was even a study where acetaminophen seemed to be rhinoprotective in severe malaria and associated with a reduction in creatinine. So sometimes, for example, it has been used in that case as a form of rhinoprotection and not as an antipyretic. About the differential diagnosis, of course, bacterial infection are well known, and even in that case, as severe malaria can be undistinguishable from sepsis, the WHO and even other guidelines recommend start an empiric antibiotic therapy while awaiting the results of a malaria test, and even the lumbar puncture if needed. Do you usually use antibiotic therapy alongside with malaria therapy while awaiting the results of the definitive diagnosis?
Excuse me, can you repeat please the question?
Yeah, I'm sorry. If do you usually use even antibiotic therapy and anti-malarial therapy while awaiting the definitive diagnosis? Just because sometimes it can be difficult to understand if patients have sepsis and or other disease or malaria.
I think for a differential, for this country, they're making the differential is a little bit easier for malaria. For malaria as compared to maybe meningitis, because the priority is start anti-malarial while waiting for the diagnosis. Because I think the feeling is malaria kills faster, and it can also be managed a little faster than the other. So by the time you're going to decide to mix antibiotic and the anti-malaria, probably the laboratory results of malaria has come very fast negative. The rapid malaria diagnosis is already negative. So immediately you can start on antibiotic while doing further investigations. This is my opinion.
Yeah, because
the clinician can talk about
I'm not a clinician, but yeah, the diagnosis of malaria the answer. I mean, it comes very, very fast. I don't know. Maybe in Italy it's not like that. Just asking.
True, I agree with you. When a patient has presented, like in most cases, if the patient is vomiting and diarrheating, we don't rush for the antibiotic because we are going to get the results as immediate as possible. What we can also put on is the IV fluids to rehydrate the patient, whereby we are expecting the results to come as soon as possible. And you know, when the malaria parasite has attacked the red blood cells and the white blood cells, there is also always some septicemia. When we see that the septicemia is really high, that's maybe when we come up with, but we get the results as immediate as possible.
And here near me, we have the laboratory technologists who can tell us how fast does the first test of malaria come out to save life of the patient. Mr. Polo is coming to.
Thank you so much. And by the name Mechanical Medical Apparatus Scientific Officer. Most cases, if we have obtained a blood sample for malaria, we prioritize it We normally make the rapid diagnosis test, which takes about 15 minutes, and the result is provided.
Oh, okay.
Meanwhile, the smear, it takes less than 30 minutes. The result is provided. And we begin with the thick smear, and then we can specify the species with a thin filling. But the results, we make sure if it is positive, it's provided as quick as possible before our diagnosis are submitted. Thank you so much.
No, thank you. Thank you. Okay, it's very clear. Thank you. Okay. So I just, here I just want to take some snapshot about the chemoprophylaxis and also the use of preventive anti-malarial medicines. In the WHO recommend three kind of patients. For example, infants, pregnancy, pregnant women, and in the case of seasonal malaria. For example, in pregnancy, sometimes if feasible, we can in the first or second pregnancies, we can consider an intermittent preventive treatment with anti-malarial drugs. But even in infants before younger than 12 months of age, where we should consider intermittent preventive treatment alongside the rounds of vaccination. And for seasonal malaria, where, for example, there are a biggest transmission in according to the part of the year in this case. And even a new for us is it has been quite impressive, and maybe probably you already know about that even before the WHO recommendation about the vaccine for children at risk. And in this case, I reported the study published in on Lancet about the efficacy and safety of the vaccine. It can, of course, not prevent all cases of malaria, but however, they can prevent a part of severe cases along with the general measure to prevent mosquito spread. And even another article published on September on the New England Journal of Medicine about the evidence of artemisinin resistance in Africa, not only in Southeastern Asia, as we discussed before. And it was quite impressive because it can even be a more challenging event for us, and even especially for you in the future. So, and just at the last part, a brief clinical scenario about a man here, so we can just discuss and proceed along with you about that. So, in this case, I choose a case of a man of that was 45 years old. His past medical history was significant for major depressive disorder, and I came to the hospital on May 2021 for fever for 5 days. He is currently unemployed and he lives in his own apartment with a friend. His history was relevant for a recent travel in Ivory Coast, and he was coming back in Italy after visiting his wife there. So, in this case, the history of illness, he had a fever for the last 5 days to a maximum of 40 Celsius degree. He had myalgias, frontal headache, vomiting, and he denies any other symptoms. On the physical examination, it was febrile, blood pressure was normal, it has the tachycardia with a normal respiratory rate. The neck was supple, and the rest of the physical examination was within normal limits. So, in this case, what are the principal suspects, in your opinion?
How long did he spend in Ivory Coast?
Just a second, please. Okay. Yeah, he came back in Italy 1 week ago, but he spent 3 weeks in Ivory Coast because he married there, so it was a long journey.
Yes, in Uganda, our primary suspicion will be malaria.
Yeah, of course. Yeah.
Because of the incubation period of about 10 to 14 days.
Okay, perfect. Yeah, for example, in our case, it was a little bit different because we considered a viral disease, of course, malaria, clearly, and even meningitis because the presentation was quite atypical. And in this, perfect. Of course, it was clearly easy. I know. And which complementary exam would you request? That's why even important, I think, for us to know how to change our practice when considering these cases.
Apollo is coming, the laboratory scientist, to take you through the laboratory request.
The first request is blood smear, where you do the thick and thin, but the thick smear would give you a better option of detection easily.
Okay.
Because you spread large cells on the smear and can make you have large density where you can easily identify malaria parasites. Whereas the thin is just now for species identification. Okay. The CBC, if it is a 5-part parameters, would really be the best. Okay. Where you have the 3-part parameters, of course, you will now go to the granulocyte part, which is the neutrophil. Of course, you will not leave out the platelet. Okay.
Okay.
Yes. CRP in any inflammatory, you will see the rise. So it is quite important also.
Okay.
Of our setting, that would be the first.
Yeah. Okay. So, for example,
on what Apollo has said, so lumbar puncture would be done after a malaria test is negative, and then other rule out or other investigations like
of course,
puncture smear to rule out meningitis will come in the virus and so forth and so on.
Yeah, of course. For example, in our cases, we perform a complete blood count, CRP, and the smear, but not lumbar puncture on our serology at the beginning, of course. Okay. So the laboratory results, the complete blood count, there was not but the white blood cell count was within normal limits. Even the hemoglobin, but there was a mild thrombocytopenia in this case. Yeah, even altered values of alanine aminotransferase, so transaminitis, normal serum creatinine, and an elevation in CRP. And the thick and thin smears were negatives. After 4 hours in the ward, the patient developed dark urine, and a urine analysis was performed with the evidence of hemoglobinuria. So in this case, which of the following is the more likely diagnosis? Of course, it's quite easy, I know. And
in our setting, it is severe malaria if because of the hemoglobinuria, which was
exactly, yeah. There was, of course, in fact, the other question, of course, malaria, but why? In our case, because there was a history of recent travel to a malarial endemic area, the presence of hemoglobinuria, but in particular for fever in that case. What do we do next? Even because at the beginning the blood smear was negative.
Because we have to repeat within 48 hours and 72 hours. The smear has to be. Hello?
Yeah. See, I'm
Yes.
sorry. Yeah. So, what do we do next time? In your opinion, we can perform a thin smear again, perform this blood smear, and immediately start a treatment. Start a treatment without repeating the smear. Just wait and observe the patient or alert the ICU physician. Or maybe there are even two or correct answers.
We remember the patient is having a high fever, right?
Yeah.
So
yeah.
You have to deal with the fever. Then you have to repeat the blood smear. And then it will give us within 48 hours, it will give us the results.
Okay. Yeah, in fact, in our cases, we perform the blood smear again and we start malaria treatment immediately. And even we alerted the ICU physician because the patient was a little bit somnolent, we have to say, and with hemoglobinuria. Okay, and or as you already said that, then the signs of severe diseases was, in this case, hemoglobinuria, of course. So a sign of bleeding and a defining sign of severe malaria. Okay, and so the evolution. The second thick smear was positive. Thick smear in that case, as you said, was positive for Plasmodium falciparum with the parasitemia of 0.8%. In that case, which regimen would you choose? Even considering practical aspects, not only, of course, the WHO guidelines.
Attachment is our first line treatment.
Yeah.
So I will choose IV attachment.
Yeah, exactly. And if not available, even artemeter intramuscularly or quinine intravenously. In that case, we started the treatment with artesunate intravenously. Okay, so thank you. My presentation is over.